Hello and welcome to episode 2 of So You Want to Be a Doctor. My name is Arnie Hill, I'm head of the School of Medicine at RCSI. In this episode, we're trying to give you a flavour of what different doctors do in their daily working lives. Before I introduce you to those doctors, if you want to communicate with us, use hashtag RCSIBeaDoc or email us at the address on the screen shown now. At the end of this episode, we hope to be able to answer most of your questions. Let's go to our first doctor. David O'Brien is a neurosurgeon who works in Beaumont Hospital and in the College of Surgeons. Now, what is a neurosurgeon? Well, it's a very exciting area to practice in. What it essentially is, he's a brain surgeon. And David looks after two areas, the brain and also the spinal cord. Let's go to David. He's going to share with us an experience on one of his patients.
My name is David O'Brien. I'm a consultant neurosurgeon and I've been here in Beaumont for the last 6 years. So neurosurgery is surgery of the brain and spinal cord and to a lesser degree the peripheral nerves. So a lot of our work here is actually opening the head, or what we call opening the tin. The types of operations we do are either brain tumours. This can be done as the patient's asleep, or some of my colleagues will do neurosurgery when the patient is awake. In other words, you put the patient to sleep, you open up the head, and then you wake the patient up and you test that you're not causing any damage to their vital functions of the brain. Other operations would include patients of brain hemorrhages or trauma. So my subspecial interest is complex spinal surgery, so I spend a lot of my work doing operations on the spine. So for example, last week I did a thoracotomy. In other words, I had to open up a woman's chest to get access to the front part of her spine. Today, in the next hour or so, I'll be operating on a patient who fell off a horse, who has fractured her spine, and we'll be putting some screws into her spine to stabilize it, a bit of scaffolding work, you know. We use a lot of computers, what we call neuronavigation. With the result of that, we make smaller holes or smaller craniotomies in the head. We get in there quicker, we just deal with the problem and get out. And patients are going home quicker. So after a major brain operation, a patient may be going home 24, 48 hours later. Typical working day for me is up at 6, cycle to work, get here between 7:15 and 7:30, walk around the place, get ready for theatre 2 days a week. I've got a clinic another day of the week, and then there's a lot of admin. I do some private practice. The other role that I would be involved with is teaching, and that might be once or twice every month. I went to college in Galway many years back. Some people say it was the last century, which is probably true. It was a process. It wasn't a defining moment when I said, yeah, I want to become a doctor. It was something that I had to do myself. Coming up to my final med, I still wanted to become a GP. You know, I thought GP was for me. But then I changed that, you know, I want to become a surgeon. I did a general surgical training scheme in Galway. Initially, I wanted to become a plastic surgeon or a reconstructive surgeon. And then, going back to when I was in preclinical years and I did a lot of anatomy, my favorite topic in anatomy was neuroanatomy. The penny dropped for me at that stage that, you know, maybe a neurosurgeon, okay? And that's why I became here. And that was a long pathway from filling out my CEO form as a 16-year-old, because I went to college when I was 17. And then postgraduately, I said, I want to become a neurosurgeon. I've been drawn to it because of its complexity. I've been drawn to it because it is tough. We have, in some cases that we do, we have no margins of error. And there's a high risk. And if you're not risk averse, you'd be drawn to something like that. So I go up to patients when we operate and I take most consent. And if I'm operating in the brain, I say 5 points to them in terms of consent. There's a risk of stroke, there's a risk of paralysis, there's a risk of infection, there's a risk of epilepsy, and there's a risk to your life. And you put that on a piece of paper and a patient has to sign it, that focuses your mind very carefully. And you know, the vast majority of times we will not have problems. But sometimes you do, and sometimes you get a complication that was unforeseen, and sometimes you lose patients. And that is tough. That's tough to internalize. But what you need as a surgeon is to say, okay, this is the job you're in. You certainly need resilience, you need compassion, and if you don't have that resilience, it won't work for you. If you ask 10 surgeons about what are the characteristics of a good surgeon, you'll get 10 or 20 different answers. So for me, it's been caring, being kind, being technically good, being dedicated, and being always there. The favourite aspect here is the people I work with, by far. They're a great bunch of colleagues, professional colleagues, nursing, medical. You know, this is the bond that you have here. So for me, if you want to do medicine, go for it. There is so many different aspects to it. Psychiatry wouldn't suit me, surgery would. But there are people out there that psychiatry or dermatology might suit them rather than being an immunologist or a cardiac surgeon. So the choice and the field is huge, but there is an area in that broad field that's suitable for everybody.
So picture the scene. You get sick and you go to your doctor and he gives you an antibiotic. Do you ever think about how those antibiotics work? Or what if they don't work? Let me introduce you to our next doctor. It's Dr. Fidelma Fitzpatrick. She's a consultant microbiologist. That's someone who specialises in bugs that are being treated by antibiotics. She's a senior lecturer here in the Royal College of Surgeons. Let's go to Fidelma and see what she does in her working life.
My name is Dr. Fidelma Fitzpatrick. I'm a senior lecturer in microbiology in the College of Surgeons, and I'm a consultant microbiologist in Beaumont Hospital. Microbiology, or clinical microbiology, is a branch of medicine that effectively brings what's happening here in the laboratory to the patient. When somebody asks me what does a doctor who's a clinical microbiologist do, I often say it's a bit like CSI. So my job is to try and figure out where a bug or a bacteria has come from and caused trouble in a patient, and how to kill it, basically. Providing advice on antibiotics is really important because antibiotics save lives. They're not just random drugs, they're very specific medications. So the bug or the bacteria that would cause a kidney infection would be very different to the bug or bacteria that might cause a chest infection. So my job is to provide the best advice on the right antibiotic. So this is the microbiology laboratory in Beaumont Hospital, and it's a very, very busy laboratory, and it works 24 hours 7. And that's because patients come to our hospital 24 hours a day, 7 days a week. And we all work as a team, the scientists and the doctors. So the scientists work at diagnosing the infection, and their specialty is finding the name and address of the bacteria that might cause the infection and the right antibiotics. And every day I'm in and out of this laboratory a lot. So a typical example of a patient I might see would be, let's say somebody came in with appendicitis. So typically they would come to the emergency department, and most likely they might end up in the operating theatre. Sometimes the surgeons in the operating theatre will send specimens down to the laboratory. And the idea of that is to make sure that there's no infection going on with the patient. So what happens then is I check in the laboratory to see has any bacteria grown, and I go and see the patient and talk with his or her surgeon, and we talk about the best antibiotic to treat the patient. So what's my typical day? Well, that's the brilliant thing about microbiology. There is no such thing as a typical day. It really varies from day to day. But certainly common themes would be I would always come into the laboratory every day to find out what's growing, what bacteria are growing here. I would always go and see the patient and put into context the results from the laboratory, because that's my job as a doctor. The other part of my job is teaching, and I teach for the College of Surgeons, and that's great fun because to me that's inspiring the next generation of doctors. The other part of my job is trying to find new things, and you can find new things by doing research in a laboratory, but also by doing some studies with patients. So for example, I might look at all the different patients that were treated with a particular antibiotic and see, is that the right thing to do? The big challenge as a microbiologist is antibiotic resistance. And the problem with that is when antibiotics were first discovered, they killed all known bugs. But because bugs are clever, they became more and more resistant to these antibiotics. And what that means is the antibiotic just won't work. So you have to choose another antibiotic and another antibiotic. So in my lifetime, and I'm qualified nearly 21 years now, I've noticed that infections that I could treat with, let's say, antibiotic A in the past, I now can't use. I have to use B, C and D. So where is all this antibiotic resistance going? Well, there's global action now, because as a society we've decided and figured out that we have to look after these antibiotics, because initially when antibiotics were first discovered, there was lots of antibiotics produced. Unfortunately now there's not a lot. So Barack Obama, David Cameron, our own government here in Ireland are now looking at trying to incentivise companies to produce more antibiotics. So how would you know if you're suited to clinical microbiology? Well, I think you have to do what you like and what you're passionate about and what you're really interested in. So when I was a medical student, I was always fascinated by bugs, and they can actually knock for six a big, strapping young person. So these tiny little bugs can cause a lot of trouble. So I was really fascinated, well, how can they do this when they're so tiny? And I was also interested in the story of antibiotics, because antibiotics were only discovered in the 1940s. And before that, people used to die of really simple infections. And then suddenly these miracle drugs came and they transformed modern medicine. So I went into microbiology because I was interested. I'm also interested in people, and I like seeing patients. Medicine's a fabulous career. At the end of the day, there's not a lot of jobs that you really feel that you've made a big difference to somebody's life. Because at the end of every day, I've the privilege of having seen somebody, hopefully made them better, and hopefully contributed to them having a better day.
Let's go to our next doctor. It's James Walsh. He's a consultant orthopaedic surgeon. Now, what's an orthopaedic surgeon? He's a doctor who fixes bones when they're broken. If you get an injury on the sports field, James is your man. Let's go over to James and see what he does for a living.
So my name is James Walsh. I'm a consultant trauma and orthopaedic surgeon here in Beaumont, and I also work in Kaplan National Orthopaedic Hospital for elective procedures. So I suppose trauma and orthopaedic surgery in Ireland involves anything from the neck down, musculoskeletal wise. Now we do have some crossover with our colleagues in general surgery in terms of trauma and our plastic surgery colleagues, but we do any broken bones pretty much anywhere in the body from the neck down. We don't do any of the neurosurgical stuff, but we'd be involved in road traffic accidents. We also do degenerative changes, so from an elective point of view, as I said, I work in Kappa. We do things like hip arthritis, knee arthritis. And my own subspecialty within orthopaedics, everyone would have their own subspecialty within the Department of Orthopaedics. Mine is foot and ankle trauma, anything from a calcaneal fracture, so a heel bone fracture, to reconstruction of the midfoot or the forefoot. Most common injuries that we see here in Beaumont, we've quite a mix of patients in terms of elderly and young patients, so that would depend often. There's seasonal variations in it. We'd see a lot of hip fractures during the week. On weekends, we tend to move to younger patients in addition to that, so tibial fractures, so broken bones in the leg from soccer or rugby injuries, foot injuries and ankle injuries, very common after Friday and Saturday nights out, and a lot of wrist injuries. But the great thing about orthopaedics is you really can get anything coming in through the door at any time, so you've got to allow yourself to get prepared for that. We do occasionally cover pitch side events when we're doing matches or things like that, so I'd see patients who are acutely injured. We generally wouldn't do much from an intervention point of view on the sideline. We just generally immobilize somebody and get them ready for further investigations and imaging in hospital, and then we definitively fix them either later that day or usually within the next 24 hours. There isn't a typical day. It's also one of the bad things that you come in the morning, you have no idea what you're facing some of the time. Now we do look at x-rays the night before, and sometimes we can see them remotely from the hospital, but a typical day would involve coming in. For example, today I'm in at about 7 a.m. for a meeting. Just before that I generally arrive in to have a quick look at some x-rays. That finishes at 8 a.m. Then I do a ward round, and then I would come down to theatre for about 9 a.m. For the first case to start, and we could go on any time till about 7 p.m. usually, and then I'd do a ward round after that and then head off home. I suppose the thing I like most about working in a hospital is working in theatre, both from the operative point of view and seeing patients come in and fixing them, but just in generally working with the team overall. There's a great mix of people and great buzz in theatre generally. It can get a bit tense at times, but most of the time it's quite a light-hearted atmosphere, not what you'd see on TV at all. In terms of negative aspects, I suppose people talk a lot about the long hours and the long training, and there's been a lot done for both of those things. We now have a working time directive, which is in its early days, to try and get hours down and try and improve people's lifestyles when they're surgeons. I think many years ago, the life of a surgeon was nothing but surgery, and that's improved substantially. In addition to that, I suppose it can be technically very difficult at times. That would be one of the challenges with it. There's a lot of challenges in terms of getting patients into the hospital. One of the big frustrations we have is actually getting to do our job, and that would probably be the biggest challenge that I would have at the present time, is actually getting the patient into the operating theatre. In terms of how orthopaedic surgery has changed over the years, it's been massive, the changes in the last 10 years. the way plates are made, the techniques we have, the imaging tools we have, we are really kind of a centre for innovation in terms of any new innovation can be used by orthopaedics. I suppose in terms of future innovations that are coming in, 3D printing and three-dimensional printing of prostheses and plates to be specific for each individual patient. I think that's one of the great innovations that we've got coming in orthopaedics, and it's something that I'm looking forward to using in the future. I don't think there's any specific skills. I think you need to be kind of mechanically minded. You need to be somebody who enjoys fixing things. Is quite an obvious thing to say, I suppose. You do need to have a bit of spatial awareness. You need to be able to understand where you are in space, often down a deep hole in a leg or an arm or a hip. I don't think there's any specific skills you need to do. You just need to be interested in anatomy. That's one of the key things. You need to have an understanding of functional anatomy and how it works in the body. In terms of whether or not to decide to do medicine, I would say it's definitely a great thing to do. I have no regrets doing medicine. In any profession you get into, you aren't the finished product when you leave college. It takes a long time to get to anywhere in any profession that you do. So in terms of the long training that sometimes puts people off, I wouldn't be put off by that at all. It's interesting. It copes with any personality type in terms of who you are and what you want to be, whether you're very academic or you're much more interested in surgery, or whether you actually don't want to deal with patients at all or love just dealing with patients. It covers all those bases. And even if after you did a basic medical degree you decided medicine wasn't for you, I think in terms of other things you can jump into, it's probably the best basic degree you could do.
And a huge thank you to James Walsh and the other two doctors who featured in tonight's episode. Please get in touch with us with Twitter, Facebook or email. We'll be right back with the live stream in just a moment. It's been a particularly exciting time in breast cancer because it's changed so much. When I started practice 15 years ago, this was a disease where there was a relatively poor outcome. And with the substantial improvements that we've made, the outcomes have really substantially improved. Just that have happened.
My life as a gastroenterologist involves taking care of patients who've got intestinal and liver problems. They have a range of abnormalities and diseases, some of which are relatively mild and some of which are life-threatening and require intensive periods in hospital.
One of the great things about general practice is you actually don't know what's coming in the door. Someone can come in, it can be something very, very simple like they just need a note from work because they've been unwell, or they could come in and they could have some really serious problem that you're very concerned about and that you need to get specialist help for them very quickly.
Hello again and welcome. I hope you enjoyed that, the second episode with the whistle-stop tour of the labs and operating theatres in Beaumont Hospital. Thanks very much to David, Fidelma and James for telling us all about their lives and what they do as doctors. Now let's take some of your questions. I see you've been busy emailing and tweeting, so I'm just going to go through some of them. Our first question from Laura is, do you need to have HPAT if you're a graduate entry student? Simple answer is no. You need a GAMSAT exam. And that's the main thing. And of course you need your undergraduate degree, you need a 2-1 in it, that's the most important. Next question here is, how can you train for the HPAT exam? Well, very simple. If you go to the rcsi.ie webpage and just go to the and go to study with us, top left hand corner. Another question coming in from Stephanie on Facebook. What's the best advice you've ever received in your medical training? Simple, be nice to your patients. And I think if you enjoy your job, that makes it really, really easy. So thank you for that question, Stephanie. Another tweet coming in here. How long does it take to become a neurosurgeon? It's about 10 years after graduation. Now that sounds like a long time, but you know, you're operating right throughout those 10 years and you're being trained, and really at that stage after 10 years you're independent and taking responsibility for who to operate on. Clearly it's an exciting area, as I saw from David O'Brien. Got another question coming in here from Even and Carl actually. How many years studying does it take to become a doctor? Well, it depends on which medical school you go to. In RCSI it's 5 years, other schools it's 6 years. But of course if you take the graduate entry route, that is, you do a degree first, then it's a 4-year degree. So it depends on which route you're choosing. In RCSI here, it's 5 years. Joanna on Twitter says, is there any extra preparation you do before a long operation? Not really. I mean, I think you just plan it and make sure that you're ready for a long procedure. You really plan your operating list each day. So if you're operating and you've got one long case, well, clearly you've got to make sure that you have enough time in the day to do that, that you put on other shorter cases. So you schedule your day, you estimate how long it'll take to do an operation, and you schedule it accordingly. So Wednesday's the day I operate, and today we had one long case and 3 short cases, and that's just the way you organize it. If you've got a very long case, you shorten the other ones and make sure you do a different procedure. Question coming in from Alex in Donegal. How stressful is it being an intern? Is it much of a jump up from being a student? Well, I think it's not, and we train in our medical school here in RCSI to make sure that you're prepared. We do actually a month as a sub-intern, so you're actually already doing a month on the job, practicing and doing everything that you do as an intern to try and make that jump from being a student into an intern much less stressful. So another question here, do surgeons need to do exercise in order to keep steady hands during operations? It's very delicate work on the spine and the brain. Well, I can tell you no special exercises are needed. It's just part of what you do every day. If you're suturing, if you're doing delicate work, David O'Brien can use a microscope. Yes, the work is more fine than other aspects of surgery, but there's no special exercises. I think it's something you decide when you start in training, that you're well able to cope with that and that you don't have a tremor. Robert and Carlo asks, what makes RCSI a unique place to study medicine? Well, I think it's the fact that, first of all, it's a wonderful location, city centre, but we have a single focus on medicine and health sciences. So if you're here, everybody is studying, 3,500 students focusing on health sciences, be it in nursing, physiotherapy, pharmacy, or medicine. There's a great infrastructure for medical teaching here within RCSI, and I think another feature is that you get excellent clinical exposure. It's done very early in your curriculum, so day one, you're into clinical training. Wonderful research opportunities, but a major feature is you have 20,000 friends around the world. They are our alumni. They are everywhere from Hawaii right across the globe to Asia, Africa, North America, and any of those you call, you get a welcome, and it helps in your training. So that's particularly exciting. We're back here. Emma on Twitter asks, how do you cope with surgical procedures that can last for hours? What's it like concentrating for that long? Is it difficult? How do you stay focused? Well, as you saw, some surgeons like to have the music on in the background. There's a lot of work going on. Does that help the surgeons operate? But the duration really doesn't bother us. You're able to concentrate on the, you want to do it right. You do it carefully. So procedures that take a few hours aren't really a problem. You actually enjoy doing the operation. You enjoy getting it right. Great relief. Genevieve has an email. She has 2 questions. Genevieve's first question is, what inspired you or motivated you to pursue a career in medicine? I was kind of motivated one time, and you can always relate it to one instant. My sister, who was a medical student, she didn't like seeing surgery, and she told me about a case of appendicitis, and I was particularly excited. I thought, God, that would be wonderful. You actually do an operation with your hands, you make someone better. That particularly appealed to me. And then another question from Genevieve, how much of a doctor's time is spent doing paperwork? Great question. A lot, too much. None of us like paperwork. But I think healthcare delivery is going to change. The electronic patient record is going to come in. It may take several years. It's certainly in place in American hospitals. So less writing with paperwork, more electronic use of recording your notes. So hopefully that will come in more and more. It's not something anyone likes, doing paperwork. Alice in Wicklow asks a question. She says, I'm squeamish and I'm concerned that I might be put off by the cadavers when she begins studying medicine. How long does it take to get over this? So firstly, let's explain what a cadaver is. When you're studying parts of the body in your first year in medical school, cadaver is a patient's body who has passed away, and you're able to study on the body. And we learn anatomy that way in medical school. And Alice